So let me give you an idea what I do every day, at least at Antec. It's a little different at the endocrine clinic. So I'm sitting at a computer, staring into a screen, and I'm seeing all this information on the computer screen. And so I'm making phone calls. That's what that's all about. I'm talking to, maybe on an average of 40 veterinarians a day. Probably 80% of what I do is talk about endocrine disease. Easy stuff like what's this T4 mean? And then complex issues like the animals with adrenal tumors. Is it a VO? Is it a cortical tumor? How do I work the case up? That sort of thing. Well, the information I'm looking at this particular day, all I know is there's a 12-year-old male neutered Boston Terrier. No pictures of it. And there's no history that I'm getting at all. And the only other thing I know is there's 2 cortisols that have been performed. I don't know what that means. It could be an ACTH response test. It could be a low-dose tech suppression where they forgot one of the cortisols. I have no idea. And then I talk to the veterinarian. I actually make a phone call, talk to him. And he comes to the phone. I've never talked to this person before. This is a fairly common scenario. And he comes to the phone, and before I can even introduce myself, say hello, how you doing, what's going on, tell me about your case, he says to me, what do you think? And this is, usually the first call I've had. I haven't had coffee yet. And I'm not in a good mood usually. I'm thinking, what do you mean, what do I think about what? And so do I look into the crystal ball and try to answer the question? And so what I thought I would do, and this, by the way, is a common scenario. I'm not just making this up to try to be funny. And so I thought I'm going to turn the tables on you and ask you what you think. Now, this is Milwaukee, right? You're outside of it. So what happens in Milwaukee stays in Milwaukee. And you'll understand in a minute. Because what we're going to do, I noticed we're playing some kind of game here. We're handing out all these prizes. Well, it's time now for the Cushing's brain game. So why am I wandering around the hall here? I'm going to ask a question. I'm Dr. Rhett Nichols. How are you? Are you a plant? We've never met before, have we? I want you to take a look at these 2 dogs. And I want you to tell me which one of them has Cushing's. And if you're afraid to commit, which tests might you do? Would you do a low dose, an ACTH response, this UT profile that everybody wants to do, but nobody can afford? Or is there some other test you would want to do? I want you to think about that. Okay. So let's kind of go over here. Or maybe I should go to the back. How do you do? Here's another 2 set of dogs. So we have this dog and this dog. Same question. Which one has Cushing's disease? If you're, again, afraid to commit, you're not sure, what test or tests would you like to do? Would it be a low dose, an ACTH response, this UT profile, the University of Tennessee, the sex story profile, the atypical Cushing's profile? Or is there some other test you might consider doing? I want you all to think about that. Let's see here. Where should we go now? Who looks like they really want to answer this question? Aha. You never look in anybody's eyes. Okay. So it looks like there's 2 animals there, right? Guess what? We're going to up the ante. We're going to go to 3 of them now. So which one do you think has Cushing's? And if you don't want to guess, or you're not sure, which test would you do? Low dose, ACTH response, or this UT profile, or some other test. So I'll tell you what I think is the most important test. And it's this test. That means a good history and a physical exam. All those other tests that I talked about are screening tests. And you want to apply a screening test to an animal that it's very likely they have the disorder. In other words, the clinical picture dictates they have the disorder. If you start applying screening tests to animals where it's not likely they have it, where the clinical picture doesn't fit, you're going to end up with a lot of false positive tests. Cushing disease, just like with hypothyroidism, there's more animals being diagnosed with it than actually have it. So the one take-home message, and I still got a lot to talk about, is the clinical picture is very important. So let me just go back very briefly. Both these dogs actually have Cushing's. This is a poster child. You're thinking, well, that's just a dachshund with a bad back. It's coming in the emergency clinic. There's probably a couple there waiting for you right now. This dog has pseudomyotonia. It's a weird manifestation of Cushing's where the muscles get really stiff and they kind of walk like this. Like some of you may be walking like that if you're staying here for the festival, for the festivities later. So this is a dachshund that truly has Cushing's disease. But the only way you're going to know is to ask the right questions. Because if you just looked at this dog, the phenotype is such that it's got a bad back, we need to operate immediately. Here's a dog, I don't know if you can see way back there, but this is a stream of urine. This dog, it's an old animal medical center days, not the greatest slide. This dog would eat food and urinate and drink at the same time. That's how bad it was. Now this dog, you look at this, it's like this Mastiff Boxer cross. And if you look at this dog, it just looks like a normal dog. This dog has an adrenal tumor. The take-home message is many dogs with adrenal tumors don't have the phenotype that you're used to looking at with Cushing's. They don't have the big pot belly. And oftentimes their lab work is just kind of ho-hum and boring. But this dog had a cortical tumor. This dog, of course, very advanced Cushing's. This is a Pomeranian. No PUPD. If you ask the history, there's no PUPD, there's no polyphagia, there's no panting. You all know what's wrong with this dog. This is one of these dogs that has, what we used to call it alopecia X. You know what happened? The dermatologists, they threw in the towel. They said, we don't know what's going on. We have no idea what's in this syndrome anymore. And now they call it the hair cycle arrest syndrome. And this little dog, this little cute dog, has diabetes, but of course has more than diabetes, also has Cushing's disease. How do you know that? You've got to ask the right questions. So the history is extremely important. But some people feel that maybe the ingredients of a good test should be what I have up here. So what are we talking about? Marlon, can we have it dimmed a little more, do you think? Is that possible?
Yep.
I don't mean it's so dark that people are falling asleep. This is a steak, or a light seven. So we're going to chop that up, and we're going to put it in this dog food bowl. And then we're going to add some really greasy commercial dog food, alcohol. And then we're going to take some can of gasoline that has gas in it, and we're going to pour it around that dog food bowl with all that stuff in it. And we're going to light it with a match. So what do we have? We have a ring of fire. Well, let me tell you something. A dog with Cushing's disease will leap through the ring of fire to get at that dog food. I guarantee you, you walk in the clinic tomorrow and there's some anorexic dog there with an Alphonse of 20,000 that does not have Cushing's. Lysogen, to my knowledge, has never been a good drug to stimulate appetite. Okay, a little breaking news, and then we're going to go on to atypical Cushing. The mini dose of cortisone. You all realize when we do an ACTH response test, one of the drawbacks is the expense. The dosage that most of you are using is 5 micrograms per kilo. Each one of those little bottles has 250 micrograms in it. What's it cost now? Is it, was it 80, $120? I can't even keep track anymore. It's like Google stuff. It just keeps going up.
About 120.
120 is what I thought. And we're using, most of us, the 5 microgram per kilo dose. What if I told you you can use 1 microgram per kilo, but it has to go IV, and you have to draw that sample pretty much at 60 minutes, not 90 minutes, not 60 minutes plus another 15, but at 60 minutes. And that will stimulate the adrenal maximally. This is just a curve showing you give 5 micrograms per kilo, It'll go up to here at 60 minutes. It'll continue to go up at 90 and then start to fall off. But we tell everybody to do a 0 and 60-minute sample. Now, if we use the 1 microgram per kilo dose, we get the same peak at 60, but after 60, it starts to fall off. That's why it's important. So you have to set the timer if you're going to use the 1 microgram per kilo dose. This is from Human Medicine. I've given you the abstract here for this test that was looked at. We've known this for a long time. It just got re-looked at and republished again. A reconstituted vial of colchicine, even in the glass, the little ampule that comes in, can be stored at refrigerator temperatures for up to 4 months without loss of potency. There's a number of studies that have looked at this in human medicine, and there's no loss of potency if you store it at refrigerator temperatures, again, for up to 4 months. So if you're doing a lot of ACTH response tests, then I think this is going to be useful for you. I would absolutely use this for Addison's disease if you're trying to rule it in or rule it out. And I would certainly use it for all your rechecks for lysogen therapy and trilostane. And then if you're really, really good with the timing, then you certainly want to use it or consider using it for your screening test for Cushing. Just remember that, in human medicine, they don't even use this test to try to diagnose Cushing's disease. They never have and never will. But we use it in our profession because it's easy to do. And I've tried to research who started all of this. I'm not sure where it all got started. But it's very difficult to get people to change their ways. But when you use this test, you're going to miss, with the PDH dogs, at least 30%. You're going to get false negative results. And adrenal tumors, about 50%. Not the greatest test in the world trying to screen, but nevertheless it is popular. So, does atypical Cushing's disease really exist? That's what we're going to talk about today. And in other words, is atypical Cushing's, classical Cushing's disease shrouded with a cloaking device for all you Star Wars and Star Trek people? Or is ACD a completely different syndrome than the classical disorder? In other words, is ACD classical Cushing's in disguise, or is it the real deal? So let me ask a question. How many cases of ACD have been documented in the veterinary literature to date? Anybody have an idea? Well, I'm throwing up some numbers here. 1 case, 3 cases, 14 cases, 50, or 100? 50. 1. 3. A lot of brave people here. Somebody's going to have those clickers and figure out. 14 cases in our profession have been documented in the literature. Now, you all know, just because it's not in the literature doesn't mean it hadn't happened, okay? But there's only 14 cases in literature. Half of those are adrenal tumors. So think about that. That means 7 dogs that don't have adrenal tumors that have been documented. Okay, so how common is this? Well, we're going to go over it. Okay, so some historical aspects so that we all are on the same page as far as what I'm talking about tonight. Because you're not going to understand a word I say if we don't really have a definition. So we're going to step into a time machine. That's me. This ugly guy in here. So we're going to go back. We're going to go back to the late 80s. That's where we're going to start our journey, in the late 80s. And we're going to go to the UK. Why are we doing that? There were 4 clinical researchers, meaning clinicians, that ran across 4 dogs. Whoop. That was scary. Okay, ran across 4 dogs. It's like a David Copperfield trick. Boom, it's gone. That were pretty much like this dog. They were all poster children for the disease. In other words, you look at the dog and say, boy, that dog must have Cushing's. We call it a parking lot diagnosis. You see him coming in from the parking lot, you know what's wrong with him. And they also had lab work that was consistent with the disorder. However, they all got ACTH response tests and low-dose text suppression tests, and every one of these 4 dogs, they were negative. Yet, everything pointed towards Cushing's, and these were very, very seasoned clinicians. So they looked at these dogs and said, boy, we're really missing something, but I don't have any idea what else to do other than treat these dogs. And at the time, that's before trilostane was looked at clinically. It wasn't available yet over in Europe. So they put all these dogs on licensure, and guess what happened? They all got better. So 4 dogs, negative ACTH response, negative low-dose dex suppression, must be Cushing, so we're going to treat them. I've talked to Mark Peterson about this, and he said, yeah, you know, every once in a while he'd run across a dog like this at the Animal Medical Center. He said, well, they must have Cushing's, who are extremely clinical, and he felt he had no option other than to trial the animals on lysogen, which was all that was available at the time. So they were put on lysogen, and thumbs up, they got better. So what in the world's going on here? So what these clinical researchers chose to do is design a so-called prospective study where they could look at another test, if you will, that might be more sensitive than looking at cortisols that are part of a low-dose dex suppression or ACTH response test. So they chose to look at this particular hormone. It's part of the steroid synthetic pathway on the way to make cortisol, and it's called 17-hydroxyprogesterone. I'll show you where it fits in the pathway in a minute. And so what they did is they took a look at a large number of dogs. 16 of the dogs had pituitary-dependent disease. They're all very, very well worked up. And 6 of the dogs had adrenal tumors. Of the 16 dogs with PDH, 3 of them were defined as having atypical Cushing's disease. It's the first time that that phrase ever appeared in the veterinary literature, atypical Cushing's. And what set these dogs apart was, like those other dogs I talked about, negative low dose, negative ACTH, but the ACTH stimulated 17-hydroxyprogesterone was outside the normal reference range. And then they looked at 6 dogs with adrenal tumors, 4 of which had this atypical form of the disease. So I'm sure it's hard for all of you to see, but their final conclusion was these results suggest that 17-hydroxyprogesterone measurements can be used as an aid to diagnose canine hyperadrenal-corticism. Now this is back in 2002. So what happens? A year later, this appears from the University of Tennessee in the Domestic Animal Endocrinology Journal. I'm sure most of you don't read this, but it's a very good journal. You can read this as well as I can. Steroid hormone concentration profiles in healthy, intact, and neuter dogs before and after cosyntropin, which is cortisone administration. This is the first paper that discussed the sex steroid profile. Right now they're doing 150 profiles a week. What's interesting, when you talk to the European endocrinologists, by the way, over in Europe, they're just leaps and bounds now, doing great research, clinical research. Before it was the Mark Petersons and the Dick Nelsons and the Ed Feldmans, and a lot of these people are taking their foot off the accelerator. And the Europeans used to come and visit these people, and now they're taking the banner and they're running with it. They're doing a lot of tremendous work. So back to UT. So then all of a sudden within a year they're coming out with this profile. Well, the point I wanted to make is when we bring up atypical Cushing's to the Europeans, they just roll their eyes. They don't believe it. They don't believe it exists. But we obviously do if we're doing 150 profiles a week. And so what do they say within the confines of this article? Measuring steroid intermediates and sex hormones reflect adrenal cortical activity. One potential application of measuring steroid intermediates in veterinary medicine is a screening test for dogs with atypical Cushing's disease. This was a marriage made in heaven. The UK researchers, their discovery, coupled with the UT profile. Again, marriage made in heaven. So here's the biosynthetic pathways. I know you hate this slide. It's like being back in school. There will be no test questions. This is what happens in the adrenal cortex, believe it or not. The building block is cholesterol. We have 3 pathways, mineralocorticoid, glucocorticoid, and androgen pathway. What the UK researchers did, they just took a look at hydroxyprogesterone and cortisol and the glucocorticoid pathways. You can see it's a precursor, if you will, of cortisol. So they just chose to look at it and with the idea that maybe that would be elevated in certain cases where cortisol wasn't. And then what the UK, or not the UK, but UT did, they looked at this pathway. They look at hydroxyprogesterone and cortisol. But they also look at progesterone and aldosterone. At least they used to look at aldosterone in the mineralocorticoid pathway. And then in the androgen pathway, they look at androstenedione, which is within the pathway, within the cortex. And they also look at estradiol. But estradiol is not made in the adrenal. It is made outside the adrenal. There's precursors that come from the adrenal that are important for estradiol synthesis, but it's not made by the adrenal gland itself. And this, of all the analytes that are looked at, we understand that the least. So nowadays, when you look at one of these profiles and you see an estradiol elevated, nobody knows what it means, and they don't even know what it means. So what are the proposed causes of atypical Cushing's disease? I'm going to try to convince you that it's one proposed cause is it's classical Cushing's disease misdiagnosed as ACD, which I refer to as pseudo-atypical Cushing's. What we're going to do is we're going to look at ACD as an onion, and we're going to peel the layers of the onion and find out what's up really underneath there. Also going to talk about aberrant receptors that are coupled to steroidogenesis. I'm sure that's a new concept for many of you. And we're going to talk about food-induced Cushing's disease, which really exists in people and in dogs. And these are either dogs or people that with every meal, they release cortisol. I hate it when that happens. And then the more meals they eat, the bigger the meal they get, the worse their Cushing's disease is. I'm going to talk about that. And some other aberrant receptors. And then lastly, I'm going to talk about dysfunctional enzymatic pathways of cortisol biosynthesis. Leading candidate is this enzyme called 21-hydroxy or hydroxylase deficiency in people, and maybe we have that in dogs. And I'm sure most of you don't understand a word that I just said, but we're going to go over that anyway because we think we're seeing some cases of this in our profession. So, proposed causes that lead to underdiagnosis of classical Cushing's disease. The other way to look at it is the overdiagnosis hypothesis of ACD. The biggest misconception, I'm going to show you an example so you can relate to it, is sex steroids equaling ACD. Everybody thinks of sex steroids, you can find them in this UT profile, it means they've got atypical Cushing's. That is a total myth, it's totally wrong. Misguided workup, screening with only one test, continued use of compounded ACTH gels. You all know that these gels, some lack efficacy, some peak early, some peak late. They're not advised. And misinterpretation of these steroid hormone profile results can create a problem. The other major category are poor screening test sensitivity. The so-called cutoffs, we call those medical decision points. When you do an ACTH response test, we do it at Antec, the cutoff is 20. Above 20, it means, well, maybe you got it. Below 20, maybe you don't. The cutoff for the low-dose text suppression is 1.4 micrograms per deciliter. Above that cutoff, consistent. Below the cutoff, it's not consistent. That's an MDP or medical decision point. And we're going to discuss this concept. What about false negative low-dose text suppression testing due to the lack of awareness and significance of what most of you have not been exposed to, referred to the inverse pattern of low-dose text suppression, which was discovered over here. Okay, are non-cortisol adrenal steroids only elevated in dogs with ACD? There's numerous studies that have looked at these sex steroids in dogs with Cushing's disease. What I chose to do is look at 4 very large studies that looked at multiple sex steroids, not just hydroxyprogesterone, threw those out. This is looking at one. They had looked at multiple sex steroids. Well, what I found is there were 70, if you combine all those studies, there were 76 dogs with Cushing's disease, 59 dogs with PDH, and 17 dogs had an adrenal tumor. And in that group, there were a couple dogs that were not classified. In other words, these are really smart people that did these studies. They couldn't figure out what's wrong with the dogs. Did they have a tumor? Were they PDH? Well, I don't know what they are, but they got Cushing's, but we're not quite sure. All of the dogs with Cushing's disease, except one. Let me say it again. Every one of these 76 dogs, meaning 75 of these dogs, that had elevated sex steroids. They had at least one or more elevated in their profile. Every one of them except one. And in a couple of these studies, they looked at dogs with non-adrenal illness. And in those studies, greater than 40% of dogs with non-adrenal illness, meaning they had something else going on that mimicked Cushing's disease, but they didn't have Cushing's disease, they had elevated sex steroids. So when you boil the fat off the stew, what does all that mean? The take-home message or impact point is that these sex steroids are commonly elevated with classical Cushing's and non-adrenal illness and are not specific for ACV. So let's take a look at Maggie, the 7-year-old female Cavalier. This is just a skin lesion the dog had. Late onset Demodex, we all know that's not normal. Pot-bellied appearance. No history of PUPD, but a low urine specific gravity. I see this very commonly. I do a lot of water balance stuff. And there's a lot of dogs out there that run around with like a 10.5 specific gravity, and the owners don't complain, and it's repeatable. I don't know why, but this is, we see it all the time. And on abdominal ultrasound, the dog had adrenomegaly bilaterally, and also had a biliary mucocele. Dogs with biliary mucocele is a major risk factor is Cushing's disease. Sharon Center out of Cornell believes that the risk factor is about 30 to 1. In other words, if you have a mucocele, there's a 30%, the odds of you having Cushing's disease are 30 times greater than not having. So what was done here, this is a dog we suspected had Cushing's disease, and this is referred over to this really good referral outfit on the East Coast, really top notch. They did a low-dose sex suppression. Well, actually, the referral veterinarian did that. This was done at Antec. And Antec's cutoff is 1.4 at that 8 hours. That's what we do. The low dose, one of the most important cortisols, that 8-hour cortisol. Remember, above 1.4, then it's consistent with the disorder. This is 0.9, so that's a normal low dose, at least by Antec standards. So what the referral place did was do one of these tendency profiles. And what they saw is the progesterone, a little star there, it's elevated. And hydroxyprogesterone was also elevated all over the handout they give to the owners. That referral letter is typed. Every other word was atypical this, or that, atypical Cushing's. This dog does not have atypical Cushing's disease. Look at the cortisol here. It's through the roof. This dog had an elevated cortisol post-ACTH. What this dog has is regular old Cushing's disease. And oh, and by the way, just happens to have 1 or 2 sex steroids that are elevated. This is what these profiles look like. They have a results section where they like to, if any of these are elevated, they like to check off here, indicate presence of increased adrenal activity. And a lot of people think that if it's sex steroids, it means they've got atypical disease. So why in the world would a dog with Cushing's disease, that we all love and know and love, have these elevated sex steroids? What's that all about? Well, let's make an analogy, a comparison. Someone is working a coal factory, and he's shoveling coal into a furnace to generate heat. So now, let's apply that to the adrenal cortex. So what's the coal of the adrenal cortex? The building block of steroid hormones. It's cholesterol. So let's shovel some cholesterol into an active adrenal cortex. So what are we going to get? We're going to get steroidogenesis. In its purest form now. We might get just mineralocorticoid, aldosterone. What species has pure aldosterone being made as part of its endocrine problem? The cat. Primary hyperaldosteronism. We think it's a leading adrenal problem in the cat. There's a subset of these cats that produce too much aldosterone. That's what's going on. It's an indication of steroidogenesis where only one hormone has been made in excess. What about cortisol as a single entity being made? Very commonly in the dog. The dog is a perfect candidate of dog, and many dogs just have cortisol being made in excess. And then, what about pure androgens? That can happen. Where does that happen? In the ferret. these ferrets that lose their hair, that have these swollen vulvas, or the males especially that become aggressive and increase sexual activity as they age and they've already been neutered. What's going on there? This is what's going on. Androstenedione is in excess. It's a male hormone. However, these are in the purest form. That's not what happens in real life with the majority of cases. You get a little of everything going on. If you look at a case study of people with Cushing disease, unfortunately women are plagued with it very commonly. These poor women, they start developing male pattern baldness. They start growing hair where they shouldn't grow it. They have virilization syndromes. Very, very common for them to produce other hormones other than cortisol. So that's what's going on in these cases. So let's take a look at Blackie now. 8-year-old female spayed mixed breed. Weakness in all legs and mild ataxia. No PUBD. Confirmed with a specific gravity repeatedly 1040 or above. Normal mentation. Normal appetite. This was sent to a neurologist because of the primary complaint. And the dog was diagnosed with this peripheral neuropathy. And, but they went ahead to be sure the dog didn't have a brain tumor, and they did an MRI. And that was clean. They did a chest rad, and that was clean. And then they did an abdominal ultrasound. The reason why they did the ultrasound, first of all, does this dog have anything that even suggests it has Cushing disease? Of course not. Okay, but why they did the abdominal ultrasound is because they were looking for cancer. Because they thought that maybe the peripheral neuropathy was related to some kind of paraneoplastic syndrome. Now, I'm just a dumb intern, so I'm not a neurologist. I'm not that smart. But so evidently there's this tie, if you will, between paraneoplastic syndromes and peripheral neuropathy. So they noticed that the adrenals are a little bit on the big side. A dog, this is like a 40 or 50-pound dog on average. If you start getting adrenals, if the width, if you will, is maybe 7.5 millimeters. You're starting to say, well, I'm a little bit big. So they're slightly enlarged. But did you read anywhere in Feldman and Nelson's book that because your adrenals are enlarged, you have Cushing's disease? I'm telling you, when we were at the Animal Medical Center, we all had big adrenals from the stress of being there all the time. So low dose was done, it was negative, but they just couldn't let go. So they went ahead and did this profile. Androstenedione was mildly elevated, a little more than mild. And hydroxyprogesterone was elevated. This dog was diagnosed with atypical Cushing's disease. How many people in this room think this dog has Cushing's disease? And not only was it diagnosed with Cushing's, atypical variety, because the low dose is negative, and the cortisols are negative following administration of ACTH. This dog was put on lice unit. And guess what happened? Got really, really sick. And do you think his neuropathy got better? Absolutely not. So you want to meet the owner? That's the owner. We're back to the beginning. This is a screening test. Tennessee profile is a screening test. You want to apply it to animals where it's highly likely they have the disorder. It's a clinical disorder. I cannot stress that enough. So what you want is you want to apply it to clinical disorders so that you can have happy findings. Enough said. So now we're going to move on to the screening tests. The screening tests, the normals they all came out of the 70s and 80s. That's when we first kind of discovered Cushing's. All these Cushing's dogs look like those pictures I showed you, or many of those pictures. Very, very advanced. Nowadays, you know, if we see a dog just gazing in the direction of a water bowl, we're working them up for Cushing's disease. And so it's out of control. And so, should they be changed? And that's the question now. The Endocrine Society is mulling over this whole idea that maybe these cutoffs that were developed in the 70s and 80s during this period where animals had very advanced disease are just too high, and we need to lower them. So let's take a look at what we have today. Just looking at all the different laboratories, not all of them, but many of them. Here's Michigan State. This is the ACTH cortisol. Their cutoff here is 20 micrograms per day, or 550 nanomoles. Here's Auburn, Here's Zurich. Now we're going to come back to Zurich. They're just like Michigan. Well, just like them as far as their normals. Now look at Antec. Still the same. Antec uses 20. Decker Pharmaceutical, they have what's called nationwide laboratories. It's a fantastic lab over in the UK. Premier laboratory. We'll come back to them in a minute. The point is, they're a little higher. One of the highest, actually, cut off. IDEX a little lower. Tennessee's a little lower. Look at Cornell and Davis. Look how low they are. So what this means is, if you do an ACTH response test and you send it to Cornell or Davis, and it comes back 17, guess what? It's consistent with Cushing's disease. If you send that same blood sample to Antec or MSU, what are they going to tell you? No, it's not consistent with it. So now let's look at the 8-hour cortisols. MSU, Auburn, and Zurich are pretty much the same. Well, they're exactly the same. About 30 nanomoles per liter or 1 microgram per DL. Antec's higher. Decker is higher than Antec, that's nationwide. IDEX is higher than either one of them. UT is somewhere between, between MSU and these commercial laboratories. Look at Cornell and Davis again. Way, way down there. So again, let's say we get a 0.7 8-hour sample. That's consistent with Cushing's at Cornell or Davis, but it's not even close. In fact, Antec, the lowest they measure is 1 microgram per TL. So they just say it's less than 1. What does that mean? Less than 1 means it's 0.1, 0.5, or 0.6, or 0.7. I don't know. So that's what the profession's debating. So are the screening cutoffs too high? It's going to go over one case, just to give you an example. And this case is actually from Zurich. It's in the literature. This is a dachshund, PUPD, polyphagia, and hair loss. And the dog was worked up very well at Zurich University. And the dog had pituitary dependent Cushing disease. They threw in the ultrasound and so forth. So let's look at the red. We're going to focus now on the 8-hour cortisol. 8-hour cortisol is 0.6 micrograms per DL. Remember their cutoff, their cutoff is 1 microgram per DL, or 30 nanomoles per liter. This is what the low dose looked like entirely, 50, 0, and 16.5. So again, the 8 hours is the key. It's below the cutoff. And they also did an ACTH response test. Their normal is 550 nanomoles per liter, came in below that. So they did a ACTH response and a low-dose dexamethasone. Both tests suggested this animal did not have Cushing disease. But there's no question it had Cushing disease. None whatsoever. Because the way it was worked up, secondly, it responded to the trials. And with complete resolution of clinical signs. If this blood was sent to Cornell, it would have been positive for a low dose. If it was, if the ACTH blood from the ACTH response test was sent to Davis and Cornell, it would have also been positive. It's all about the cutoff. The problem is, if you lower cutoffs, you make them too low, what is that going to do with specificity? It's going to create more false positive testing. Now, in the hands of Dick Nelson and Ed Feldman, they're pretty good at discriminating who has Cushing's and who doesn't. But some veterinarians don't have the experience, and they just look at these numbers, and they buy every number they see. So let's go back to the original study, the original UK study, where all this got started, back in 2002. If we take a look at the results of the ACTH response testing and low-dose dexamethasone testing, it's quite surprising. 54% of these dogs in this study had a negative ACTH response test. In a bad day in the ACTH response test world, you might get 30% that are bad, not 50. So what's going on there? So let's look at the world of the low-dose dexamethasone. Nearly 30% of all the dogs in this study had a negative low-dose dexamethasone test. What's that all about? In the world of the low-dose dexamethasone, Ed Feldman's going to tell you, based on all these cases he's seen at Davis, maybe 5% of dogs that truly have Cushing's are going to have a negative low dose. And now we're talking 30%. Why is that? Well, here's probably why. This is all done at Cambridge Specialty Laboratory, which is now nationwide. They changed their name. They have the highest cutoffs in the profession. They nearly have a cutoff. The ACTH is 22, and their low dose is nearly 1.5. If they were using lower cutoffs, I'll bet we wouldn't have so many of these dogs that were misdiagnosed, so to speak, we think. I told you there's 14 cases in the literature of atypical Cushing's. Half of them were diagnosed in this one study. So it makes you think, it's food for thought. Okay, recognizing the inverse pattern, a low dose with inverse test results. Some dogs with Cushing's will have a 4-hour cortisol above the cutoff. I'll show you a picture of this. I hate stuff like this. And all these written words. And 8-hour cortisol below the cutoff. What they did was, they went back, one of these retrospective studies, and they looked at all these dogs with Cushing's disease that they had diagnosed. And they had 80 of them. Or 80 dogs with Cushing's that had a normal low-dose dex suppression result. And they found that 10 of the 80 dogs, they had found 10 of 80 dogs had a normal low-dose dex suppression. And 5 of those dogs out of the 10 had the so-called inverse pattern. And so they went on to say that the inverse pattern is suggestive of Cushing's, but it's not diagnostic. None of these tests, as you know, are foolproof. So the lack of awareness of this inverse pattern may lead to misdiagnosis of classical Cushing's. Okay, what in the world is the inverse pattern, right? Okay, here's the escape pattern. Cortisol ghrelin ratio after a meal. Guess what? It's food-dependent Cushing's disease until proven otherwise. You're saying to yourself, why is this guy talking about some case that I'm never going to see in my lifetime? Some rare thing that belongs in a museum. What if I told you they're seeing 1 case a month at Utrecht? And why they have, because they finally figured out this is occurring. It's still not common, but because they see a lot of Cushing's cases. But the reason why they're seeing it is they understand what to expect now, and they're trained the veterinarians what to look for. And so at any rate, they did the same thing on day 2, and you can see here's the urine cortisol creatinine ratio at 8.4, and they gave the meal, and boom, it almost tripled. So when you double, that's what you're dealing with until proven otherwise. So again, and they did ACTH levels, which if it's a pituitary-dependent dog, you'd expect it to be normal to elevated. And this dog had bilaterally enlarged adrenals. What you find in these dogs is oftentimes their low-dose dex suppressions and ACTH response are kind of equivocal, but their adrenals are enlarged. And if you were to look at an ACTH level, and I realize that most of you don't do ACTH levels as part of your Cushing's workup because of the expense, but nevertheless, if you did, and if you found a dog with big adrenals and bilaterally and low ACTH levels, then you're onto something. So I've gone over the pathophysiology. And so the endogenous ACTH levels are suppressed. 3-hour post-meal UCCR is generally twice that of the resting level. And the way the dog was treated, they used trimestane. By the way, that's what they use in Europe now for the most part. Lysotret is considered a very dangerous drug over in Europe. In fact, when Mark Peterson, years and years ago, he went to the FDA to try to get Lysotret approved for use in dogs. And he took data from 200 cases to the FDA, went to Washington, D.C. to talk to them. And they looked at all his data, and they said, we're not going to approve it. And he said, well, why? We said, because it's too dangerous, is what they said. But, for those of you who use it, if you treat it with respect, it's a good drug. So they fed these dogs 2 hours prior to the meal. This dog was only ate once a day, so it made it easy. And they fed 2 hours prior to the meal, and that suppressed the cortisols from the meal. So what other aberrant receptors are out there? Was there a lot? I just want to talk about one more before I close this section. Here he is again, the king of receptors, Andre LaCroix. And In 1999, he published an article on gluperolide acetate therapy and luteinizing hormone-dependent Cushing syndrome. This is a woman that she had a child who went to full term, and during that period, she started to develop signs and symptoms of Cushing's disease. Then she had 3 other children, and every time that she went full term, she would develop signs and symptoms of Cushing's. Then she finally went through menopause, and when the hormones are raging, LH levels are just all very, very high. And then she developed full-blown Cushing's disease when she went into menopause. And went to see this guy, and he figured it out. It was all about LH, and aberrant receptors of LH in her adrenal cortex was what's causing the Cushing's disease with her. So he gave her a choice. He said, well, you know, we can give this drug, this is a gonadotropin-releasing factor hormone agonist, if you will. At first you give it, it increases LH activity, and then it shuts it down, it downregulates receptors. He says, we can give this drug, or we can take out both your adrenals. It's up to you. What's your choice? Well, she elected to get the drug, and it worked very, very nicely. She got a shot every month, and her Cushing's went away. So do we see this in veterinary medicine? Absolutely. We see it in the ferret. The ferret is LH-dependent hyperadrenal corticism. They have functional LH receptors that play a major role in the pathogenesis of their problem. But what's interesting, not all the ferrets have functional receptors. You can find these receptors in their adrenal cortex, but they're not always functional. So it's a fascinating complex. What Sarah Gallick did, she took a look at the expression of receptors for LH and GIP, let's just limit it to that, in normal dogs and dogs with adrenal tumors. And when you're a molecular research scientist, you ask 2 questions. Is there a genetic basis for a certain gene? And is the gene active? In other words, you're going to determine messenger RNA using quantitative PCR techniques. That's the blueprint of a protein, such as a receptor protein. And then if you can find the messenger RNA, that blueprint, then you want to see if they can make that protein, if you can find the protein. And you do that by using Western blot or immunohistocytochemistry. This is a cut through a normal dog's adrenal. She was able to find that in normal dogs, they have GIP receptors. That's immunostaining. That means all normal dogs have the GIP receptor in their cortex. But it's a rare clinical finding. What this means is the receptor's there, but it's not functional in the majority of dogs. So let's take it a step further. This is a cut through a normal dog's adrenal cortex, and she did immunostaining for the LH receptor. What they're finding is in the dog, the ALH receptors are there, but clearly they're not functional because these dogs, you can inject LH and they're not going to produce cortisone. So the question is, what's turning on the receptor? And it's just a matter of time until we document dogs that have this LH-dependent hyperadrenal corticism. So aberrant receptor wrap-up. Most of the dogs aren't in advance like this. This is our, I think you've seen this dog before. That's in the advertisements for Veteran. This dog is actually, his name is Bolo, and he's ball in Spanish. And the Carlos Mealy, I don't know if you know, he's a very famous Spanish veterinarian. And he's probably seen as many dogs with Cushing's as anybody. He believes in BID trilostane therapy. This is his case. And these dogs typically, with these aberrant receptor dogs, they may not be positive for ACTH or low dose. In other words, those tests may be negative. But they will have enlarged adrenals, and they will have depressed ACTH levels. And it's all due to these aberrant receptors. So there's a small percentage of dogs that's what's going on with their Cushing's disease. Okay, and lastly, this particular syndrome, 21 hydroxylase deficiency. So what in the world am I talking about here? Okay, and then we're going to talk about some cases, like some real cases and how you might want to handle them. This is an ACTH-dependent hyperplasia-related dysfunctional enzymatic pathway of cortisol biosynthesis. Does that mean anything to you? Well, it'll become clear in a minute. The most common form is 21-hydroxylase deficiency, and this defect can be mild or severe. So what does it all mean? Well, the take-home message is we believe there could be some cases of atypical Cushing's that could be this adrenal hyperplasia-like syndrome. That's the question we're asking. So we're going to look at this pathway right here, right here. That's the cortisol pathway. If we go from hydroxyprogesterone over here to cortisol, this is an enzyme, 21-hydroxylase. It's very, very important. What if that's dysfunctional? What if that enzyme is operating at about 10% its normal level? In other words, it is dysfunctional. What's going to happen is hydroxyprogesterone is going to build up, and then that's going to get converted into this male hormone, androstenedione. So cortisol biosynthesis is inefficient at the expense of increased levels of hydroxyprogesterone and androstenedione. So does this happen? Let's take a look. Before we take a look, 21-hydroxylase deficiency leads to low cortisol, leads to increased ACTH. So how can we shut down ACTH? What's the cheapest and easiest way to do it? Just give some cortisone. How many people would give cortisone to a dog with Cushing's disease? Well, you would think twice before you would do that, right? It's an excess of cortisone state. And that will shut down steroidogenesis and will shut down these hormones. Here's Casey, male castrate shepherd mix. PUPD, this dog had a 10-1 urine-specific gravity. It's like what? Food aggressive. This is some of the new behavior. This would just tear and just try to eat the stainless steel bowl where the food was being put. It was so food aggressive. The cortisols, ACTH stem cortisol, look at this. This is barely out of the resting range. This is very blunted stimulation. Here's a dog that's acting like it has the worst case of Cushing's in the world and has a blunted response to ACTH. What's that all about? Sometimes you see that with adrenal tumors, but this dog did not have an adrenal tumor hit by bilaterally enlarged adrenals. So why in the world would it have this blunted response? Look at the androstenedione level. It was so high it couldn't even be measured. Look at progesterone. It was so high it couldn't even be measured. 17-hydroxy, too high it couldn't be measured. In man, when you have a post-ACTH 17-hydroxyprogesterone greater than 15 nanograms per ml, it's highly suggestive of this particular syndrome. So we thought, well, maybe this dog has this syndrome. So, Mr. Scientist, meaning me, I said, oh yeah, it must be one of these hydroxylase deficiency syndromes, maybe. I said, well, let's put your dog on cortisone. Well, that didn't work. Okay, I drank more than ever, and the owner just wanted to kill the veterinarian because the veterinarian listened to what I had to say. So maybe if we kept it on longer, it might have worked. A large subset will turn into carcinoma, which can be resected. You can take if the whole lobe is not involved, you can resect a piece of these carcinomas out. Many of these Scotties will live for very, very long periods of time. Her other comment is, everybody's always worried about alphos. She sees Scotties that have 20,000 alphos levels of their normal lifespans. The biggest thing that makes her worried is that there's an acute elevation in alkaline phosphatase, and that makes her think in terms of dysplastic lesion, carcinoma, or a biliary mucocele. Those are the first three things she thinks about. Here is the Scottie, the Scottish Terrier. It's the same dog. Look at the cortisols, they're not that bad. Androstenedione, look at this. Progesterone, hydroxyprogesterone, just off scale. Enlarged hyperechoic prostatomegaly, very low specific gravity. Many of these dogs, as you know, with Cushing's develop proteinuria, about half of them. Same with blood pressure. The low dose, one of these equivocal low doses. And this dog was put on lysergin and clinically did much better from a clinical point of view. So what's happening is, for those of us, it sounds like I'm trashing these Tennessee profiles, but for those of you that are doing them, now we're asking ourselves, could they help us make a decision on which drugs to be using in some of these dogs, like the Scotty, for example. So now, this is leading to what I refer to as a resurrection of lysergin. If I ask an audience, like this audience, look, they give them the choice, which drug are you going to use? We'll use hands. Are you going to choose lysergin or trilostane for your Cushing dogs? So how many typically would choose trilostane? Okay. Well, let's ask the other question. How many would use lysergin? Interesting. Well, it's not half and half. I went to Ed Feldman Coaching. That's out there. I had to give a talk in Sacramento, which is right next to Davis, California. And Ed Feldman has convinced everybody trilostane is the worst drug on the planet. And he's taught them all how to use lysergin safely. That's the way it is out there. So I asked people, how many people use trilostane? I think 2 people raised their hand. And I said, well, how many people use lysergin? And everybody raised their hand. And usually, if I ask that same question, I go to the East Coast. I mean, like, this is kind of like Midwest. But if I go to the East, like Washington, D.C. or somewhere like that, everybody raises their hand when I say trilostane. And I say, does anybody use lysergin? No, we don't use that stuff. So it's amazing. It's really, really a big difference and a major influence. But it's being resurrected now for those people that are discovering, especially in breeds like the Scotty, this so-called adrenal excess syndrome. So people ask, well, you know, if the cortisols, the low dose, and the ACTH response tests are negative, then why would these dogs be PUPD? Why do they show signs of Cushing's disease? And so the Tennessee people took a look at this, and they took, it's not a big study, but they took a look at healthy dogs, dogs with ACD, and PDH dogs that had standard old Cushing's but is pituitary dependent. And they looked at hourly cortisol concentrations over time. So here's your healthy dog, your cortisols, they're down here. Here's your PDH dogs, they're up here. But look at this. Here are your atypical Cushing's dogs. They're not as high as the PTH, but they're definitely higher than normal dogs. So what it's telling us is that if you look at the amount of cortisol they're secreting over time, it's higher than normal. And that's probably why they have the clinical signs, but they may be not as advanced as we see with many of our straightforward Cushing's dogs. So, take-home focus. We've already talked about the cutoffs. We talked about this inverse pattern. Now you're wondering what this slide's all around, right? Keep an eye out for food-induced Cushing's. And maybe in the future, where somebody in this room, smarter than I am, will stumble across the first LH-induced hypercorticism dog. Remember, they all got the receptor, and one of these days, one of those dogs is going to turn on that receptor. When that's going to happen, I don't know. And the dogs will look like that. Okay. And then we have this debate, if you want to call it that. We've got 2 drugs. Fortunately, we've got 2 drugs we can use, and either lysergin or trilostane. For the most part, dogs do pretty well on trilostane, especially if you're giving a BID, as I mentioned. But we have some dogs that are refractory to it, and we definitely have to use lysergin. And certainly in the Scotty, or a dog with these massive elevations in the, especially in the male hormones and cortisol, it makes a lot of sense to use lysergin therapy. So just remember, often patients do not have what we know, they have what they have. Thank you. I hope that didn't bore you.